Welcome to Doctors on Call. I'm Jenna Miller. A gynecologist is a doctor who specializes in women's reproductive health. Obstetricians care for women during their pregnancy and just after the baby is born. They also deliver babies. An OB-GYN is trained to do all of these things. Your OB-GYN will deal with some of the most important issues of your life, including childbirth and menopause. An OB-GYN can also screen for cancer, treat infections, and perform surgery for pelvic organ or urinary tract problems. What can you expect on your visit to an OB-GYN? Women's health, that's our topic today on Doctors on Call with our guest, Dr. Jenna Sloan.
Presentation of Doctors on Call is made possible in part by an underwriting grant from Gove County Medical Center in Quitter. Healing through caring.
Blue Cross and Blue Shield of Kansas, serving approximately 950,000 Kansans in various programs. A value Kansans trust. Blue Cross and Blue Shield of Kansas, an independent licensee of the Blue Cross and Blue Shield Association.
Neighbors, friends.
Welcome back to Doctors on Call. Our topic tonight is women's health with Dr. Jenna Sloan. Dr. Jenna Sloan received her medical degree from the University of Kansas School of Medicine. She completed her residency in obstetrics and gynecology at Baylor Scott and White Memorial Hospital. Dr. Sloan is on staff at the Center for Women's Health at Hayes Med, part of the University of Kansas Health System. Give us a call at 1-800-337-4788 toll-free with your medical questions about women's health on Doctors on Call. Doctors on Call brings you information which may be useful to you when you see your own physician. Thank you so much for joining us tonight. We're going to get started with some questions right away. First of all, let's talk about how do you find an OB-GYN that you feel comfortable with and can trust?
Sure, I think that's a great question to start with. So I would say someone who you feel comfortable asking questions of is probably the most important thing. Making sure that that person answers your questions in a way that you can understand, that leaving your annual exam or your consult visit that you have a clear understanding of what the plan is moving forward and why that plan is important. So just someone who really empowers you to understand your health better. Someone who really teaches you about whatever disease condition or maybe just teaches you about the importance of preventative health. To me, those are things that are really important to look for. So just making sure that you can communicate with that person effectively. Okay, now I have to ask, do you find that women gravitate to you more because you are female? I think that's really tricky, especially in my clinic. There have been, the majority of providers have been male for a long time, and I think a lot of women have really grown to trust those men to be their providers, and that's awesome. And then there are other women who just feel more comfortable with a woman or who have had a history of physical or sexual abuse or other experiences, or maybe they have something really difficult to talk about, like painful intercourse, that they just find it easier to talk with a female about those things with. So I think yes and no, but I know that again, you learn to trust the person, especially who's gone through those really big life events like a birth of a child, or if you needed a hysterectomy, you really grow to trust that person regardless of their gender.
Okay, excellent. When is it recommended to start seeing an OB-GYN?
Also a great question. Mm-hmm. So if you're having a problem that you think a gynecologist or obstetrician could help you with, I would say that is the right time. So I've seen really young patients in my clinic. Unfortunately, sometimes that's due to a trauma, like let's say a little girl falls off of her bicycle. Sometimes we'll see girls really, really young if they've had some sort of trauma like that, or unfortunately if there's sexual abuse. But then, you know, as women enter their teenage years and start having periods, that's another really common time for them to enter our clinic. And so if your periods are really painful and causing you to miss school or miss sports, that's a frequent time for us to start seeing patients. That doesn't necessarily mean that we will have to do an exam. So I think that's one of the biggest fears of patients coming into my clinic is, you know, you're a 14-year-old sitting on the exam table and you think that you're going to have a pelvic exam. And a lot of times that's not the case. A lot of times for especially our pediatric patients, we can help treat their problem without an exam. So don't let that stop you from coming to clinic or bringing your daughter or granddaughter to clinic. I think that in general, though, when a woman becomes sexually active, it's important to start seeing a primary care provider or a gynecologist for reproductive health issues. And then now the current recommendation is for pap smears to begin at age 21. So that's a long answer to your short question.
No, absolutely great information. How important is it when you come in to see you to know your family history?
For obstetrics and gynecology, that's actually really important. So in obstetrics, for example, something really important to know is if there's a family history that's strong for blood clotting disorders. When it comes to gynecology, knowing your family history of cancers is really important. So particularly breast cancer, ovarian cancer, colon cancer, uterine cancer, it's important to know. And unfortunately, families haven't always talked about these things in detail. Someone will say she had uterine cancer when in fact maybe it was cervical cancer or breast cancer. So it's not always easy to get that detailed family history, but to the extent that you can, it's good to bring that information with you.
Okay. If somebody doesn't know about their family history, or maybe there's an adoption in the family, how can they go about getting that information?
Well, currently the guidelines are not necessarily to screen someone for a hereditary cancer gene unless there is an indication for that. So most of the time that does require them to have some knowledge of family history. So like you said, for adopted patients, it would probably have to be a personal history that led to that, or a symptom that they were having that could lead to that genetic screening. But in general, we can do a lot with knowing if you're having any symptoms or any problems and go from there.
Excellent. All right, we're going to go to the phone lines. We've got a caller waiting to ask a question. This is Montine on the line from Beloit. Hi, Montine. Go ahead with your question for Dr. Jenna Sloan tonight.
Hi, Jenna. Hello, Dr. Jenna. I recently had a hysterectomy within the last year, and I have put on weight since then, and I'm very active. I eat healthy, but I don't know if it's related with the hysterectomy, and if so, is there anything in addition to what I'm already doing as far as eating healthy, exercising, lifting weights? Is there anything else I can do to help with this?
Sure. I don't know if you can hear me now, but were ovaries removed at that time?
No.
Okay. So, in general, that is a fairly common problem to have some weight gain after hysterectomy. Definitely more common, though, if ovaries are removed, and that's something I take a particular interest in my clinic, is helping women with that middle life weight gain, because really we want you to feel much better after your hysterectomy. There was a reason that you had a major organ removed, and so we want you to feel better after that major surgery. So one thing, in addition to what you're already doing, there's some recent data. It's a study called the Empower diet, or the Empower study, and Empower with an IR. And that data came out and talked about women who were going through or nearing that menopausal transition, that they were really able to effectively lose weight and keep it off if they kind of restructured how they eat. And so what I mean by that is really focusing on vegetables and lean proteins for the first part of the day. And then after 4 p.m., you can add in some healthy carbohydrates. They also did an arm of that study where they looked at adding a medication called metformin. And so metformin is something that is typically used for diabetes. But in reproductive medicine and in weight loss medicine, it's really, the use of it is being expanded. And so whether or not that is the right diet for you and the right medication for you, that would be something more specific to look into. But there is really good data to say that a particular diet with the medication metformin can lead to long-term, slow, steady weight loss. So definitely don't feel like you don't have any options.
Okay. So it's common for a person after a hysterectomy to gain weight like she was talking, or not necessarily?
I don't know if there's specific data on what percentage of women do gain weight, but I would just say anecdotally that that's a common complaint in my clinic, even if ovaries were not removed. So.
Okay, excellent. Let's talk about some of the important things that a woman can do to protect her health.
Sure. So what our last caller mentioned is really, in my opinion, the best place to start. So really prioritizing exercise and healthy eating. Focus on filling as much of your plate up with fresh produce as you can, focusing on intake of lean meats and just a variety of healthy foods in general. That's probably the best place to start. And then beyond that, there are a lot of things that your gynecologist can help you with. So making sure that you're staying up to date on your preventative maintenance. That's not just limited to pap smears and pelvic exams and breast exams. That also has to do with as you get a little bit older, thyroid screening and screening for diabetes, screening for osteoporosis. So just to name a few, those are important things to really keep on your checklist. Am I getting enough calcium? Am I getting enough vitamin D in my daily life to make sure that I maintain my bone health into that menopausal transition?
Okay, what are involved with those screenings? Are they blood tests? How do you screen those?
So for screening for thyroid disease, diabetes, high cholesterol, those are all a blood test. So a simple blood draw that you have drawn at the lab. For screening for osteoporosis, we're going to look at your bone mineral density. And so that really is based on age and risk factors when that's recommended to start. But again, the most important steps you can take to prevent that are intake of calcium and vitamin D, and then also weight-bearing exercise. We know that's really important for maintaining your bone health. As far as screening for cervical cancer, that's the traditional pap test that everyone knows about. And I think an important distinction to make is that when we say pap smear, that is looking specifically at the cells of the cervix. So as a part of your pelvic exam, your gynecologist may or may not collect the cells on the cervix, just kind of depending on where you're at in your screening and if it's indicated to do a pap that year. That's something we hear a lot, that a patient thinks they've had a pap smear if they went to the ER, but probably they at the ER just had a pelvic exam. So it's important to stay up to date on the pap screening as well.
Okay, and you said that starts at 21 and then that's once a year, or how often does a woman need to come back?
Again, the guidelines have changed and it's made it super confusing for patients. But in general, if you're attending an annual exam, so a yearly exam, then you will definitely stay up to date. For patients who are younger, if they have all normal pap smears, current guidelines are going to be for collecting those cells in the cervix about every 3 years. And then once you reach age 30, if all of your pap smears have been normal, then we can add a test called HPV testing, or human papillomavirus testing, and that will potentially make it so that you only need the pap and the HPV testing every 5 years.
Okay. Now, we've talked in the past, when we've been talking about women's health, about the guidelines changing for self-breast exams. Can you keep us up to date what's going on now?
Sure. So the current recommendation for self-breast exams is more about self-breast awareness. So knowing your breast tissue, being aware that if you're still having menstrual cycles, that it's going to change throughout the cycle, and really checking your breast tissue in that week following your menses is a good time, that it's not going to be quite as hormonally active, and so less likely to scare yourself. But again, anytime there is a concern, we want you to come in. We want you to let us know if there's a concern. As far as mammography screening, there are different organizations that have different recommendations. So for the College of Obstetrics and Gynecology, that's going to be for a yearly mammogram starting at age 40. I try to talk with my patients about, the different recommendations of different organizations and try to give them a fair idea of, that there is some differing opinion out there, but several organizations recommend yearly mammograms starting at age 40.
Okay. And you hear a lot about the digital mammography. Is that different than your traditional mammograms?
Oh, that's a really good question for a radiologist, but my understanding is that it is going to give the radiologist a much more detailed look at your breast tissue. And so, to my knowledge, all of our mammography at HaysMed is currently digital.
Excellent. All right, we want to remind our viewers that we are talking about women's health tonight. You can give us a call at 1-800-337-4788. Our guest tonight is Dr. Jenna Sloan from HaysMed. So give us a call if you have a question about women's health. Let's talk about pregnancy, and we'll start with, do pregnant women need to take prenatal vitamins?
Sure. So it's recommended to start a prenatal vitamin several months before you're thinking of trying to conceive. And if you weren't planning to conceive, then we recommend starting a prenatal vitamin just as soon as you realize that you're pregnant. The reason for that is that folic acid is particularly important for development of the neural tube, which is our spinal cord. And so by making sure that you get enough folic acid, the likelihood of a spinal cord defect is lower. Otherwise, in addition to lots of other vitamins, the next most important ingredient of a prenatal vitamin that I encourage my patients to keep taking it for is the iron. So as you get into the third trimester, the later part of pregnancy, the likelihood of anemia is a lot higher. And so if we can keep iron not only in your diet, but also in your prenatal vitamin, that really helps prevent that.
Okay. Now, I hear some women do so well on the prenatal vitamin during pregnancy, they want to just keep taking it after. Is there any benefit to doing that?
Sure. So after you deliver a baby, you're also really high risk for having anemia. So excellent idea to stay on the prenatal vitamin for that reason. And also, a lot of women aren't sure, do I want to have another baby? How soon do I want to have another baby? And so if you're not actively taking something for birth control, it's a really good idea to stay on it for that instance as well.
Okay, excellent information. We are going to go to the phone lines again. We've got Lou on the line from Hays. Hi, Lou. Go ahead with your question for Dr. Jenna Sloan tonight.
Yes, after you've had a hysterectomy, do you still need a pap test?
Excellent question. So that really depends on what led up to your hysterectomy. It's a fairly safe bet that if you never had any abnormal pap tests before your hysterectomy, so let's say you had completely normal pap smears every year or every 3 years or every 5 years leading up to your hysterectomy, that you do not need a pap test after your hysterectomy. If, however, you had abnormal pap smears, it's super important to talk with your doctor about the potential for needing a pap test, because sometimes if that human papillomavirus had caused abnormal cellular growth at the cervix, and that was present at the time of hysterectomy, there's a small potential for that to reoccur in what we call the vaginal cuff, so that vaginal tissue that remains at the top of the vagina. So great question to ask your doctor based on your history of pap smears leading up to hysterectomy.
Was there any instance when a hysterectomy can be avoided?
Sure, yeah. So there are lots of different treatments that we can use to try to help a woman's bleeding. I would say that's the most common reason for hysterectomy, is if a woman is having periods that are problematic. So periods can be problematic in lots of different ways. They can be really heavy to where it's hard to get out of the house. They can be really prolonged. You can have bleeding between periods, which we also consider to be abnormal. You could have bleeding after menopause, which should always be evaluated. So there are lots of different reasons that can lead to it, and depending on what the reason for the consideration of hysterectomy is, really helps guide the treatment. So a common treatment that's not hysterectomy would be a pill. So some of those pills contain 2 different types of hormones. Some just contain 1 type of hormone. Depending on your age, would kind of guide which pill was indicated. But for a lot of women, we can get bleeding somewhat under control with just a pill. For other women, something called an IUD or a levonorgestrel IUD. A common brand name would be like Mirena or Liletta. A lot of younger women use Kyleena or Skyla, but those intrauterine devices have really decreased the rate of hysterectomy in the United States because they're very effective at controlling bleeding. The initial studies talked about 60% of women not having a period at all with an intrauterine device, 80% of women having an improvement in their bleeding. And so for a lot of women, that's really helpful for them. Beyond that, there are some more specific treatments, just kind of depending on the bleeding pattern, but ablation, when we essentially burn or treat that entire uterine lining that is shed every month with a period, that is another treatment that can be used instead of hysterectomy. It's definitely less invasive than a hysterectomy. Can sometimes help a woman avoid having to take time off of work. Those are the main treatments that come to mind.
Absolutely. Great. Now, what about progesterone? How beneficial is that for a woman to take? Or you hear the progesterone creams. Let's talk about that a little bit.
Sure. Progesterone alone is really tricky. So everything surrounding hormone replacement therapy really evolved while I was still in medical school with the Women's Health Initiative. So prior to that study, a lot of women were taking hormones for better or for worse. But during that very large study, we learned a lot about specific groups of people, and we learned a lot about women who were just taking one type of hormone. So for example, taking estrogen without a progestin, if you still have your uterus in place, can increase your risk of uterine cancer. Taking progestins alone can increase your risk of breast cancer. And so it really needs to be carefully considered for each individual woman based on their symptoms, based on what their needs are, and based on what the potential consequences of being on a particular hormone replacement therapy is going to be for that woman. What we do know from the Women's Health Initiative, as more data has come from that trial, is that if a woman starts hormone replacement therapy closer to the onset of menopause, then the likelihood of adverse effects of hormone replacement therapy is diminished. So all of that should go to say that, if you're really struggling with hot flashes, night sweats, vaginal dryness, come see your gynecologist sooner rather than later.
Mm-hmm. Okay. Can you define menopause?
Sure. That is the absence of menstrual bleeding for a year. And that can be really tricky for women because as they get closer and closer to menopause, their periods tend to do one of two things. Often they will spread out. So a woman could have, a period 1 month and then go 3 or 4 months without a period. And so it's kind of harder to keep track, but absence of periods for a year. The other potential possibility as a woman nears that menopausal transition is that periods could get a lot closer together. And that's when we see a lot of really frustrated patients because, they're going along fine, their periods were fine, and then all of a sudden, instead of being a monthly period, they're having 2 periods a month. And they're just as heavy. And it's really impossible for us to say exactly how long that's going to go on for a woman. But again, come get it checked out if it's bothering you.
Okay, and what can a woman do to help herself, I guess, through those years and through that transition?
Sure. So in addition to the treatments we talked about earlier for abnormal bleeding, one thing that I didn't mention earlier that's a non-hormonal treatment that is appropriate for some women is a medication called Lysteta. And so what it does is just decreases the bleeding during the cycle. So that's a good tool in our toolkit to help women who either don't want to be on a hormone or don't want an intrauterine device to help her get through those really frequent heavy periods.
Okay, let's talk about thyroid disease and how common that is.
Sure. To my knowledge, it's very, very common. The likelihood of a woman developing thyroid disease at some point in her life is even as high as 1 in 8 women. And so screening for thyroid disease really starts in your clinical exam, talking about, if you've had any changes in your hair or your skin or your nails, changes in mood, changes in weight. Those are things that I always talk with all of my patients about who are coming for an annual exam or an infertility visit. because it is so common and it's easy to screen for. And if that's the cause of one of those things, we want to identify that as quickly as possible.
And how treatable is thyroid disease?
Very treatable. So for some women, they're lucky and they get on a certain dose of thyroid replacement and they get to stay on that same dose. Other women struggle a little bit more because of the way that their thyroid disease is occurring. So they'll have what's sometimes referred to as like a thyroid burnout, to where we have to adjust their levels of thyroid medication more frequently. But again, very treatable with thyroid replacement. The less common of the thyroid diseases would be hyperthyroidism, but again, very treatable.
Okay, excellent. Wonderful information tonight. Thank you so much to Dr. Jenna Sloan for being our guest tonight. Thank you for joining us for Doctors on Call. I'm Jenna Miller.
Doctors on Call is made possible in part by an underwriting grant from Gove County Medical Center in Quitter. Healing through caring.
Blue Cross and Blue Shield of Kansas, serving approximately 950,000 Kansans in various programs. A value Kansans trust. Blue Cross and Blue Shield of Kansas, an independent licensee of the Blue Cross and Blue Shield Association.
Russell Regional Hospital. Experts, neighbors, friends.